Moving on to healing by regeneration. Regeneration returns an injured or lost tissue to its original state. The regeneration of injured cells and tissues, it involves the proliferation of the cells. This is brought out by growth factors. Sir, what are the requirements? It requires the integrity of the basement membrane, integrity of the cell architecture, extracellular matrix, and also tissue stem cells. So what are the cells that proliferate during healing? There are many types of cells that proliferate. So if, for example, if there is liver damage, the liver hepatocytes themselves regenerate. So the remaining cells of the injured tissue, also vascular endothelial cells for angiogenesis, and also fibroblasts for fibrosis. And the type of cells or tissue capable of regeneration also decides it. So regeneration occurs in tissues or organs with labile cells such as bone marrow hematopoietic cells or surface epithelial cells, or stable cells, so liver cells, kidney cells, fibroblasts, etc. The new cells are derived from tissue stem cells and rapidly proliferating immune progenitors. However, in permanent tissues such as neurons and cardiac muscle cells, the cells cannot regenerate. The healing is only by scar fibrosis. Okay. So healing may be either by regeneration or repair, or both. With mild and transient injury, there is regeneration. But if there is chronic injury or chronic inflammation, if the damage persists, there is fibrosis. Okay, so there is repair. So steps in healing by repair or scar formation, what are there? First, there is inflammation. Whenever there is tissue injury, inflammatory reaction begins, which tries to limit the damage and remove the injured tissue. Next, there is cell proliferation. So several types of cells such as epithelial cells, endothelial cells, fibroblasts, they proliferate. So epithelial cells, they migrate over the wound to cover it. Okay, endothelial cells, they proliferate and form new blood vessels, and fibroblasts, they form a scar. Next, granulation tissue. In the first 1 to 3 days, 24 to 72 hours of the repair process, it begins with proliferation of fibroblasts and vascular endothelial cells. A specialized type of tissue, see, granulation tissue, it is a hallmark of healing by regeneration. Okay. So hallmark of healing wounds, okay, it derives from pink soft granular gross appearance of granulation tissue. Okay, so the vascular endothelial cells proliferation and fibroblast proliferation. Okay, so microscopy, you can see proliferating fibroblasts. Obviously, you can see scattered chronic inflammatory cells. You can see angiogenesis, new small blood vessels. They are thin-walled, delicate leaky capillaries. They allow the passage of plasma proteins and fluid into the extravascular space, and the leakage of plasma proteins and fluid is responsible for edema seen in granulation tissue. Amount of granulation tissue formed depends on the size of the tissue deficit created by the wound and also the intensity of inflammation. Next, angiogenesis. Angiogenesis, what happens is, first there is vasodilation due to VEGF and nitric oxide synthesis. Next, there is separation of the pericytes. Okay, here you have pericytes, right? So the pericytes, they separate from the abluminal surface of the blood vessel. Next, the basement membrane itself breaks down. Next, there is migration and proliferation of the endothelial cells towards the site of the injury. Okay, there is a tip cell. Next, there is maturation of the endothelial cells and remodeling into capillary spouts or tubes, and then there is formation of the mature vessel. So finally, there is suppression of further endothelial proliferation. What are the signaling factors? So pericyte recruitment is done by angioproteins 1 and 2. Next, sprouting or branching of new vessels is via the Notch signaling pathway. Next, endothelial proliferation and pericyte recruitment, again it is by VEGF-A and also FGF2. Scar formation, the leukocytes, edema, and angiogenesis, they disappear. Okay, wait, this is the structure of granulation tissues. Here you can see epithelium, discontinuity lined by ulcer, and here you can see blood vessels, angiogenesis, fibroblasts, okay, fibrous cells, and also inflammatory cells. Okay. Next, scar formation, you can see leukocytes, edema, and angiogenesis which disappear, and there is increased accumulation of collagen. The granulation tissue scaffolding is converted into a pale avascular scar. The components of the scar, you can see collagen, fragments of elastic tissue, and fibroblasts and other ECM components. So connective tissue special stains, you have trichrome stain. It contains 3 stains which stain red cells into orange, muscle into red, and collagen into blue. Next, you have elastin stain or von Giesen stain. It identifies elastin, and you also have reticulin stain. It is present in early scars, and also by the end of the first month, the scar consists of acellular connective tissue without inflammatory infiltrates. And after the formation of the scar, there is remodeling to increase its strength and contract it. In fibrosis, mainly there is type 3 collagen. But basically, you need to remodel it after a few weeks by matrix metalloproteinases and put type 1 collagen there. So TGF-beta is a potent fibrinogenic agent which stimulates ECM synthesis. On the other hand, the degradation is brought out by matrix metalloproteinases because they are dependent on metal ions, zinc, for their activity. The connective tissue in the scar continues to be modified and remodeled. Remodeling is an important feature. Okay, it indicates the equilibrium between ECM synthesis and degradation has been restored. What is the role of macrophages? They clear the offending agents, they provide growth factors, and secrete cytokines for fibroblast proliferation. Moving on to cutaneous wound healing. Healing is defined as, see, there is healing of a clean uninfected surgical lesion by primary union or by first intention. So first we need to know the timeline. So day 0 there is blood clot. Day 1 there is neutrophilic inflammation on the along with the blood clot. Day 2 blood clot, neutrophilic inflammation and thin epithelial layer. Okay, if this is the discontinuous epithelium, there is a blood clot first, beneath that neutrophilic inflammation, and then on top epithelial layer. Then on day 3 there is granulation tissue with macrophages, fibrous tissue, fibrosis and angiogenesis, fibroblasts. And day 4 or 5 there is increased type 3 collagen. Day 5 there is maximum angiogenesis, and day 14 there is increased collagen and fibrous tissue. And after a few weeks, what happens is there is remodeling. So the type 3 collagen is replaced by type 1 collagen. So that is what happens. Surgical incision causes a death of minimum number of epithelial and connective tissue cells. The disruption of epithelial basement membrane continuity is also minimal. Re-epithelialization occurs by regeneration, and there is a relatively thin scar. So first 24 hours, what happens is there is a formation of blood clot which contains not only trapped RBCs but also fibrin, fibronectin, etc. It stops the bleeding and acts as a scaffold for migrating and proliferating cells. Dehydration at the external surface of the clot leads to formation of a scab over the wound. Next, within 24 hours of the wound, neutrophils appear at the margins of the incision and they release proteolytic enzymes to clear out the debris. Next, epithelial changes. Neutrophils came now at the cut edges of the wound. The basal cells begin to show mitotic activity and they proliferate across the wound. Okay, along the dermis. Now, 2 days. What happens is neutrophils are replaced by macrophages. So macrophages, they play a central role in the repair process, and epithelial cells, they fuse in the midline. Next, 3 to 7 days. What happens is granulation tissue begins to invade the incision space. So the surface epithelium, surface epidermis, it achieves its normal thickness and there is acute inflammatory response. It begins to subside because granulation tissue brings macrophages, chronic inflammation. So acute inflammatory response begins to subside. The angiogenesis is maxed by 5 days. Collagen is progressively laid down. So 10 to 14 days, again there is leukocytic infiltration, edema, angiogenesis, which all of them, they disappear in the second week. And there is increased collagen deposition and regression of the vascular channels. So the granulation tissue scaffolding is converted into a pale avascular scar. So weeks to months, the scar appears as a acellular connective tissue covered by intact epidermis and without inflammatory infiltrates. So the collagen deposition along the line of stress and wound gradually achieves 80% maximal strength of normal skin. Healing by second reunion or second intention. When the injury produces large defects on the skin surface with extensive loss of cells and tissue, the healing process is more complicated. Healing in such cutaneous wound is referred to as second reunion or second intention. So first, larger wounds, they show more exudate and necrotic tissue. So the clot or scab formed at the wound is large. Okay, and also severe inflammatory reaction is there. Large inflammatory reaction because of larger defect and greater necrosis. Larger defect requires more granulation tissue, large granulation tissue, and excessive deposition of collagen with substantial scar formation. It needs to retract. So there is wound contraction also. Wound contraction generally occurs in large surface wounds, and it's an important feature in healing by second reunion. So myofibroblasts of granulation tissue have ultrastructural features of smooth muscle cells. They help in wound contraction. So wound strength, the major portion of the connective tissue is type 1 collagen, and it is responsible for development of strength in the healing wounds. So at the end of the first, 1 week, 4 weeks, 3 months. 1 week the wound strength is 10%. 4 weeks it gradually increases and then it decreases the rate of wound strength recovery. Next 3 months it reaches 80% of tensile strength of unwounded skin. Okay, so here you can see what happens in order. So first you have a large clot that is being formed. Then there is acute inflammation. Okay, and also the cell proliferation begins and large amount of granulation tissue is formed, and also the wound is covered on entire surface by the epithelium. Okay, collagen fibers are deposited and granulation tissue is replaced by a large scar. So differences, what is there is nature of the wound is clean surgical wound. Opposite, margins are clean, irregular margins. Sutures, it can be used in primary intention but not in secondary intention. Infection is absent, this may be infected. Amount of granulation tissue, it is small, it is large. Outcome, it is a neat linear scar, irregular contracted scar. Okay, complications are rare and infection. Moving on to factors that influence wound healing, we have local factors or factors that delay wound healing. So basically any infection, any movement of the area, or if there is any foreign body, infection or foreign body at the injury, movement of the injured wound, and if the size of the wound is large, then the wound healing is delayed, and the location again. So especially if the wound over the skin covering the bone, such as on the anterior tibia, there is a little wound contraction. It prevents wound contraction. The edges of the skin lesions in such locations cannot be opposed. Then again, blood supply. So varicose veins of the legs, they decrease the venous drainage and they can cause non-healing ulcers. And bed sores also, they can diminish both arterial and venous blood flow. Radiation decreases repair process, and complications may delay wound healing. Factors that favor wound healing: small wounds and larger blood supply, and on areas such as the face, they heal faster. Systemic factors: you have nutritional deficiencies such as protein deficiencies and malnutrition. Vitamin C deficiency, it inhibits collagen synthesis and retards healing. Trace elements: copper and zinc deficiency, zinc for metalloproteinases. Okay. And age: wound healing is rapid in young people. Metabolic status: so diabetes mellitus, it is associated with delayed wound healing due to microangiopathy. Circulatory status: there is inadequate blood supply. If there is that due to arteriosclerosis or venous abnormalities, they delay healing. Glucocorticoids, they have anti-inflammatory effects and they impair wound healing. And also hematological abnormalities, they delay wound healing. And vitamin C, it is essential for synthesis of collagen. It is an antioxidant and it is a reducing agent. So it decreases the cross-linking of trophocollagen and deficiency, and also it decreases the tensile strength of the wound. Zinc acts as a cofactor in collagenase. So what are the complications of wound healing? First, there is inadequate granulation tissue formation. So DUI is a mnemonic. So first there is dehiscence. So the wound splits open, or there is rupture of a wound, which is the most common life-threatening complication after abdominal surgery. It is due to increased abdominal pressure or mechanical stress on the abdominal wound from vomiting, coughing, etc. Next, ulceration. So wounds can ulcerate due to inadequate angiogenesis during healing. So wounds in the leg of patients with atherosclerotic peripheral vascular disease or varicose veins, they usually ulcerate. Varicose veins ulcers, okay? So non-healing wounds also develop in regions devoid of sensation. These neuropathic or trophic ulcers may be seen in diabetic peripheral neuropathy and nerve damage from leprosy. Next, incisional hernia. It results from weak scars of the abdominal wall due to a defect caused by prior surgery. They are due to insufficient deposition of extracellular matrix or inadequate cross-linking of the collagen matrix. Next, excessive scar formation. You can have hypertrophic scar. The accumulation of excessive amounts of extracellular matrix, mostly collagen, may give rise to a raised scar at the site of the wound known as a hypertrophic scar. They usually develop after thermal or traumatic injury, and they involve the deep layers of the dermis. Keloid. If the scar tissue grows or progresses beyond the boundaries of the original wound and does not regress, it is called a keloid. So if you excise it, and it recurs as a still larger keloid. Next, exuberant granulation or proud flesh. So basically it is a pyogenic granuloma or granuloma pyogenicum. It consists of localized formation of excessive amounts of granulation tissue. Okay, you can see neovascularization and all that, exuberant granulation tissue. And this projects above the level of the surrounding skin and prevents re-epithelialization. It is known as proud flesh. Next, desmoids or aggressive fibromatosis. Incisional scars or traumatic injuries may be followed by excessive proliferation of fibroblasts and other connective tissue elements. They are known as desmoids or aggressive fibromatosis, which may recur after excision. Next, excessive contraction. Decrease in the size of the wound due to myofibroblasts is known as contraction. The exaggeration of this contraction is named as contracture. It results in deformities of the wound and the surrounding tissues. The consequences are they compromise movements. So contractures that follow severe burns, they compromise the movements of the involved region, or they can obstruct. So in GI tract contracture or stricture, there could be intestinal obstruction. Others, there could be infection of the wound. Epidermal cysts can develop because of persistence of epithelial cells. And again, there could be pigmentation due to either colored particle left in the wound or due to hemosiderin, or there could be neoplasia. And fibrosis, so normal wound healing is associated with deposition of collagen. The excessive deposition of collagen and other ECM components in a tissue is known as termed as fibrosis. TGF-beta is an important fibrogenic agent. So examples of disorders with fibrosis, you have cirrhosis of the liver, pneumoconiosis, chronic pancreatitis, and glomerular nephritis.